Liver cysts. Liver cysts are either simple polycystic liver, hydatid disease of the liver, cystadenoma, and cystadenocarcinoma. Simple cyst, it occurs in 2 to 20% of the population. It may be single or multiple. It is usually filled with serous fluid and lined by cuboidal epithelium. More common to be in females and more common affecting the right hepatic lobe. The liver simple liver cyst is usually asymptomatic. A large cyst can cause dull ache pain in the upper right abdomen. Sometimes they cause compression on the bile duct or inferior vena cava. The most important complications are hemorrhage and infection of the cyst. Ultrasonography and CT scan are very good methods for diagnosis of simple liver cyst. Most of simple liver cysts don't require any treatment, only follow-up. These are indications of surgery for cyst more than 6 centimeter, cyst causing pressure. If it is suspicious for hydatid cyst, or we are suspecting a cystadenoma. Polycystic liver disease occurs in association with polycystic kidney disease. Patients are usually asymptomatic and discovered accidentally. Symptoms include hepatic enlargement and pressure effect. Acute abdomen may occur due to hemorrhage or infection inside. CT scan is very good modality for diagnosis of polycystic liver, as shown in the diagram. Strategies are the same for treatment of simple hepatic cyst, either to follow up or to excise or aspirate or whatever, with putting in consideration that if the condition is massive, the patient will need liver transplant. Liver cystadenoma is the most common primary cystic neoplasm of the liver. It occurs also in females between 40 and 60 years of age. They are asymptomatic and sometimes also they cause upper abdominal pain. Diagnosis of liver cystadenoma is based mainly on ultrasonographic findings. The sonar can say it is a liver cystadenoma, and analysis of the cyst fluid shows elevated carcinoembryonic antigen 19. Liver cystadenoma, they have risk of malignant transformation, so they should be resected with clear margin. Hydatid cyst of the liver, it is a parasitic disease caused by Echinococcus granulosus, and it is very common in Mediterranean countries. The definitive host is the dog. The intermediate host are the sheep, camel, and goose. A man can act as intermediate host. It is not transmitted from man to man. This is the life cycle of hydatid disease. These areas where hydatid disease is endemic. Hydatid cyst occurs mainly in the liver 70%, but it can occur also in the lung 20 to 30%. In bone less than 10%. Brain and heart are not common. In the liver it can be single or the layer of the cyst are very important. The outer layer, it is a fibrous layer formed from the liver. It is called the pericyst. The innermost layer is the germinal layer, which produces the daughter cyst, the scoliosis, and the hydatid fluid, surrounded by another layer for protecting the cyst called the laminated membrane. So it is a three-layered cyst, but two-layer organism because the fibrous outer part belongs to the host. Usually it is asymptomatic, sometimes cause upper abdominal pain, dyspepsia. Some people present with its complications. On examination, there may be hepatomegaly, palpable mass, right upper tenderness. The most important complications are a rupture into the biliary tract and it may cause obstructive jaundice. It may rupture in the peritoneum, causing acute abdomen and anaphylaxis. It may rupture into the bronchial tree and cause bronchobiliary fistula. Infection is common and it turns to an abscess. On examination, there is on diagnosis, there is eosinophilia by CBC. ELISA and complement fixation tests are accurate. Abdominal ultrasound shows this floating membrane, which is very important sign called water lily sign. And triphasic CT also shows a daughter cyst and this water lily sign or the floating membrane. Sometimes this hydatid cyst does not need any treatment if it is asymptomatic, less than 5 centimeter, or totally calcified hydatid cyst. It needs no treatment. Otherwise, treatment should be done, and there are 3 options. If the patient is high risk, only medical treatment is sufficient. Percutaneous aspiration is an option. Surgery is the gold standard option. Concerning surgery, there is partial hepatectomy if the cyst is very large. Another option is just drooping of the cyst or removal of the cyst, and all this should be done under coverage of albendazole. During surgery, precautions must be taken not to soil the abdominal cavity with the scoliosis or the hydatid fluid. So we should pack the abdominal cavity with packs soaked with hypertonic saline or povidone iodine, the scolicidal material. We should aspirate the cyst first, then inject inside the cyst before deroofing hypertonic saline or povidone iodine. This is illustration for a cyst that underwent deroofing. Thank you so much.